Now let's talk about GI problems as it relates to medication. So again, diving into the common medications we got over here on the list. We'll start with antibiotics. I just want you to understand that there are nutritional consequences to virtually every medication that you take. Antibiotics are no exception to that rule. I've listed out a number of the different types of antibiotics and names of antibiotics here on the left side. And so in the center here, what we have are the different nutrients that are impacted. Now this is a massive list, but the first that we're going to call out, and it's not really a nutrient, but it's very important for nutrients, and that's your microbiome, right? We oftentimes refer to your gut flora, your healthy flora, or healthy bacteria as your microbiome. Now these bacteria are very important, and remember, antibiotics aren't specific for bad bacteria. Antibiotics, they're broad spectrum. They're going to wipe out massive amounts of your microbiome. Antibiotic use has been linked to a number of problems. One of them, though, is an increased risk of obesity. We see that we saw this originally in farm animals. So like on a farm, it's commonplace, if you want to make your cows fatter, give them antibiotics. They'll gain a lot of weight a lot faster. You'll be able to sell them for more money because they're fatter, they're heavier. But we know antibiotics can increase obesity. Simultaneously, we also know that antibiotics, as they knock out your flora, will increase the risk of a yeast overgrowth or a yeast infection. Those of you who've heard of Candida. Candida is a type of yeast. But when you increase the risk of a yeast infection, the problem with yeast, is yeast can cause GERD. And, that GERD, that symptom of GERD, I just say technically GERD is gastroesophageal reflux disease, but technically speaking, yeast doesn't cause that. Yeast just causes inflammatory damage to the stomach that feels like the symptoms of GERD. So really, if we're being technical about it, yeast and overabundance of population of yeast can damage the esophagus, the stomach, the small intestine. Yeast can grow orally. That's what doctors oftentimes, if you ever had a white coating on your tongue, they call that thrush. So chronic antibiotic use can also do this. Now, the problem here is that yeast will take your B vitamins. So they'll hijack your B vitamins, so they'll steal those from you. And B vitamins, of course, necessary for energy and nerve function and heart function and vascular flow and a number of other functions in the body. Very important. And so that's where we come to this. So you can see here the B vitamin deficiencies, all B vitamin deficiencies linked to antibiotic use, partly because of this yeast connection, but also partly because of this microbiome connection. Your microbiome, your good bacteria actually make B vitamins. They're responsible for synthesizing B vitamins. And some of the B vitamins that we get, this is especially true of the B vitamin biotin. It's estimated that between 50 and 60% of your biotin is derived from your microbiome. The same is true of vitamin K. So very, very important for these two. The abundance, almost half, in some cases more than half of these two vitamins are made or produced by the microbiome. And so if you are chronically being exposed to antibiotics, whether it's prescription drug antibiotics or antibiotics like pesticides in the food that you're eating or antibiotics like chlorine in the water that you're drinking, you're going to diminish your ability of your GI tract or your microbiome to produce these types of vitamins. Now, again, vitamin K and biotin on the higher end of that spectrum, but the other B vitamins are also produced by the microbiome, and anywhere from 10 to 20% of your daily need can come from the microbiome. So that chronic antibiotic use can really, really pose a risk and problem for your B vitamin production. We also got potassium, and this is specific to penicillin and amoxicillin. And calcium deficiency, which is specific to tetracycline, magnesium deficiency, and iron deficiency, and zinc deficiency. Again, all of these minerals specific to tetracycline and minocycline and doxycycline. So if you're, I see this a lot in people that have been treated for chronic Lyme. They're on long-term doses of doxycycline. I've had people come to see me and they were on these antibiotics for years at a time. Again, and in many of these cases, their doctors weren't testing calcium, magnesium, iron, or zinc to see that they were maintaining an adequate status in these minerals. You don't want to become deficient in these minerals because the long-term consequence, the obvious long-term consequence here is these are minerals that are necessary for bone health, but calcium and magnesium are electrolytes as well, so your nerve health is dependent upon them. Your hormone health is dependent upon them. Magnesium has arguably more than 700 functions in the human body. You don't want to deplete that particular nutrient. It's just too important. Of course, iron deficiency can cause anemias, which overlap with a lot of the diseases, or a lot of the symptoms of the Lyme disease that's being treated in the first place. And so that would be things like brain fog and fatigue and muscle pain, which is, again, those are hallmark symptoms of Lyme, but you can cause an antibiotic iron deficiency anemia that can lead to very similar types of symptoms. So again, trying to avoid that. Now, let's talk a little bit in detail. I want to just put a few things up on the screen for you from the literature. So this is a study published in the Journal of Pharmacology and Technology. And so just as a summary, I want to give for those of you who like to chase down the research, and we'll have these slides available in our community tab. So if you're part of our YouTube and you subscribe to our YouTube, we have a community tab where we put these images up for you in case you want to go grab them and chase down the resources. But as you can see here, this is coming from Medications and Micronutrients, Identifying Clinically Relevant Interactions and Addressing Nutritional Needs from Jeffrey David Prescott et al. Common drug micronutrient interactions. You can see here, in this case, these are all antibiotics. Here we go. So antibiotics, penicillins, biotin, vitamin K, what we were talking about earlier, cephalosporins, zinc and vitamin K, fluoroquinolones, calcium, magnesium, zinc and iron, tetracyclines, same four minerals, trimethorphan, vitamin C and folate deficiencies. So again, a lot of nutritional deficiency coming from the chronic use of these antibiotics. Now, I want to be clear, if you need an antibiotic, if you have a major infection and you're going to die from that infection or you have a life-threatening situation, please, don't construe this as medical advice to not use an antibiotic when it's necessary or needed. But take this information so that you have it, so that you can be a good, judicious person when it comes to your doctor wanting to prescribe antibiotics without doing their own diligence, right? My advice on any antibiotic is if your doctor wants to prescribe one, have him confirm that you need one. Confirm via culture. Cultures are ways that doctors can identify different microorganisms, different bacterial microorganisms, because a lot of infections, and this is especially true of sinus infections, which is a common reason why kids and adults today are prescribed antibiotics, is they're fungal. As a matter of fact, there have been a number of research studies showing that the vast majority, 80+% or more, of upper respiratory sinus infections are fungal in nature. And if you give an antibiotic to somebody with a fungal infection, what ends up happening is you make the fungal problem worse. You increase the growth of the fungus because the antibiotic destroys the microbiome. It destroys the flora. Remember, there's a balance between fungus and bacteria in your body, and if you have a rapid depletion of good healthy bacteria, then the fungus, the yeast themselves have no competition. So now they get to grow out of control. They don't have any competition for the resources. They get stronger and stronger. And one of the byproducts of different types of yeast, and as they're living in you and colonizing you, aside from just the infection itself, they release toxins, these toxins called mycotoxins, which many of them are cancer-causing toxins. And so long-term, they can create some real risk for some major disease problems, but aside from the acute risk of just having the acute infection. So you got to make sure that if you want to use antibiotics judiciously, if you need them, ask your doctor to confirm that you have a bacterial infection by using a culture. Because if he's not confirming through culture, you might be taking an antibiotic that doesn't do you any favors. And if that's the case, it's doing you harm. It's not just benign. Antibiotics that are just in case antibiotics are not necessarily benign. They're dangerous if you don't need them. So again, use them judiciously. Now I wanted to show you this here as well, because I just showed you that antibiotics cause B vitamin deficiencies. And so I just wanted to show you, this is a review published in the journal Microorganisms on the role of B vitamins in gut health. So kind of going through this, some of the functions of B vitamins as it relates to your gut and your gut health. And remember, it's gut health that we're talking about here. So vitamin B1 deficiency, okay? Abundance of Peyer's patches, size of the B cell follicles and B cells number. So you need vitamin B1 for the immune system. These Peyer's patches and B cell follicles and B cell numbers, these are all immune cells that are there to protect your GI tract. So vitamin B1 deficiency reduces the abundance of these very important immune tissues. Vitamin B2 deficiency, you can see impairment of intestinal cell growth. So remember, your cells are supposed to turn over in your gut every 2 to 7 days. Your cells turn over, your gut lining is brand new. And what we're saying here is that impairment of intestinal cell growth, defective mitosis, which is part of cell growth, and accumulation of aneuploidy cells in the colon. Vitamin B3, relapsing inflammatory bowel disease. There's some research that shows that niacin deficiency can actually cause villus atrophy. And this is especially important for those of you maybe with celiac disease, where you were diagnosed because your doctor found villus atrophy in your small intestine. Well, vitamin B3 deficiency can cause villus atrophy. So if you're a celiac and you're going back to your GI doctor, maybe you've been on these chronic antibiotics for a time, you're low in B3, now your intestines are atrophying as a result of that B3 deficiency and not necessarily gluten exposure. That's vitamin B3. So ask your doctor again. The key is ask your doctor to test your nutritional levels periodically to avoid all of these problems. Then we have up here vitamin B6. So you get, with vitamin B6 deficiency, you have a reduction in mucus secreting cells. Remember, mucus is the substance that lines and coats the GI tract. It offers a layer of production. You also have a reduction in intestinal short-chain fatty acid production. I talked about short-chain fatty acids a moment ago in mentioning that they are the fuel source for the colon cells. And then this triggers the inflammation during inflammatory bowel disease. So again, vitamin B6 deficiency, not a good thing to have when you're dealing with antibiotics. Intestinal carcinogenesis. So this is vitamin B9 or folate. And colon cancer is what that basically means, or intestinal cancers are linked to folate deficiency. Also, increased intestinal mucosal crypt depth, mucosal cell division, and crypt mitosis in duodenum and jejunum. Another hallmark or another type of finding that's very common in celiac disease. Increases goblet cells and abundance of Paneth cells in the ileum, and reduces apoptosis in the epithelial cell together with B2, B6, and B12 deficiency in the colon. And this is why it increases the risk for cancer. Apoptosis is when you kill abnormal cells. It's a process that your body goes through to kill off abnormal cells before they turn into cancer cells. And then there's B12 deficiency, and you can see here, reduces similar changes in intestinal mucosa as that of B9. So, the same kinds of findings with B12 deficiency is what you find with folate deficiency. Reduction in villus-crypt ratio, shortening of villi, again, villus atrophy, right? Intestinal cell differentiation. So reduction in how intestinal cells can differentiate and grow and replicate. So affecting that 2 to 7 day turnover time. Both folate and B12 are very critical for this time framing. And this is one of the reasons why a lot of people receiving chemotherapy medications, their intestines are so upset, their GI tracts are so damaged and upset, and they have nausea and diarrhea. It's because they're depleting B12 and folate, which is leading to this very type scenario right here. But again, antibiotics, chronic use of antibiotics can also contribute to this. Okay, enough about antibiotics. Let's move into some of the other medications. Let's talk a little bit about laxatives. There's different kinds of laxatives. Predominantly, we'll talk today about a few. There's osmotic laxatives. These are laxatives that bring water into the bowel. And so they basically, that excessive water helps with the flow of a bowel movement. This usually causes loose bowel movements. But common examples of osmotic laxatives include polyethylene glycol, also sometimes referred to as PEG, P-E-G. There are a number of different over-the-counter, you could go buy it any local drugstore that are PEG-based or polyethylene glycol-based osmotics, and then there's lactulose. Both of these types of chemical compounds can deplete your minerals, potassium, sodium, calcium, and phosphorus. Again, not a good thing if you're using it's one thing if you use it very sparingly every once in a while, but if you're a chronic laxative user, this is a bad deal. And there have actually been some research studies in elderly rest homes where they actually found, and we can just draw it here, where they found that the elderly that were chronically using laxatives also had increased risk for vitamin B12 deficiency, which isn't listed in this, but there is research pointing to that. And again, in the elderly, B12 deficiency, one of the things it causes is atrophic gastritis. So it causes the lining of your stomach to start to break down and become inflamed. And when your stomach lining is inflamed, you become less apt at absorbing and digesting your food, especially protein, so you can become protein malnourished. And in the elderly, that's a bad thing because it leads to something called sarcopenia, age-related muscle loss or muscle loss, which, you know, that's going to cause muscle weakness, reduction in exercise, reduction in overall function, and increased risk for a host of other problems, including bone loss, muscle wasting, etc. So, again, if you're chronically using them, big problem. If it's you know, sparingly once or twice in a year, something along that line, you're probably not going to run into major deficits here. Now, some people are allergic. It's not an uncommon thing. There are PEG allergies. So, you know, some people can react to an osmotic diuretic in a bad way because they're allergic to it, but this nutritional aspect is more along the lines of chronic use. And then stimulants. Stimulant laxatives like bisacodyl deplete potassium. And remember, potassium is an electrolyte that helps to regulate the contractility of muscle. Your intestine's a muscle. It contracts and relaxes. That contractility and relaxation, that's called peristalsis. It's what allows you to have healthy bowel movements. So this, using these over time, when you affect your electrolytes, you're actually, by default, you're going to impact your peristalsis. And this is why a lot of people get addicted to laxatives, because as they're using them to have a bowel movement while not solving why they're constipated, they're creating a secondary electrolyte deficiency that over time leads to greater degrees of constipation, making them more and more reliant on these medicines to have just a decent bowel movement. And then there are stool softeners. This one being like a Fleet suppository. A lot of people use suppositories to get bowel movements, and these suppositories have been linked to calcium and magnesium deficiency. Mineral oil, not a suppository so much as people will take it orally. They'll actually drink it, and this stuff is no good. It can lead to vitamins A, D, E, and K and beta-carotene deficiency, as well as a loss of calcium and phosphorus. So again, the bigger question here is if you're having to rely on laxatives to have a bowel movement, the bigger question is why? And I want to encourage you, we'll put a link below. If you're constipated, I have a crash course on overcoming constipation that I want you to go and watch. And again, I'll put that link below in the description for you. Okay, moving into the next class of medications, the anti-inflammatories. And so there's NSAIDs, which are non-steroidal anti-inflammatories, and then there's steroids. These types of medicines are commonly prescribed. Sometimes NSAIDs are prescribed just for general inflammation control. Steroids are oftentimes prescribed for inflammatory bowel disease, right? And sometimes we'll see doctors prescribing both of these in people that have IBD to bring the inflammation under control. Of course, a lot of different deficiencies, for these different classes of medications. Non-steroidals can deplete vitamin C and folate, B12, potassium, iron, and magnesium. Steroids deplete A, C, D, folate, calcium, magnesium, potassium, and zinc. So again, not anything that you want to be on for any great length of time, because again, these nutrients, when you deplete them chronically, the consequences to those depletions can become life-altering. And in this case, a lot of this, magnesium, calcium, zinc. What are we talking about here? We're talking about muscle health. And particularly, we're talking about a reduced muscle. So reduced muscle or atrophy of the muscle, which is going to impact the way you move, the way you're able to exercise, the way you're able to function. One of the predominant causes of pain is lack of movement and sedentary behavior. One of the predominant causes of constipation, as we were talking about a minute ago, is lack of movement. Part of the way we stimulate healthy bowels is through motion and mobility, right? So when you walk, your tailbone, it twists, it creates a figure 8-like motion, and it pulls and it tugs, and it helps supply the nerves and the spinal cord with a bathing of cerebrospinal fluid, and all of this helps to stimulate healthy bowel function as well. So you don't want to cause deficiencies of these very critical electrolytes to help play a role in that neurological communication message. Then you have probably one of the biggest classes of drugs prescribed today and abused today. I'd say second probably to antibiotics would be your antacids. And there are a number of different, there are what are called generally PPIs, and then there are H2 blockers, H2 antagonists, and then there's also just your classic kind of antacids that work directly in the stomach by neutralizing acid. And so these different types of medications are going to deplete nutrients that require acid for absorption. Predominantly that's vitamin D, B12, folate, calcium, iron, zinc, and protein. Of course, these are all ones that have been studied and reported on in medical literature. And again, the consequence to these nutritional deficiencies is not good. Now I want to dive into some of the research on this one as well. So, and some of the consequences. So what you're looking at here, this is a summary of potential drug interactions and known risk factors. This was published in Pharmaceutics, Evidence of Drug-Nutrient Interactions with Chronic Use of Commonly Prescribed Medications. And you can see here in this, we're talking about antacids or acid-suppressing drugs, in this case, proton pump inhibitors. You can see a decrease in the following nutrients: B12, C, iron, calcium, magnesium, zinc, and beta-carotene. And then over here, again, if you want to chase this reference down, all the research studies where they've looked at this and found these to be true. And these are human studies, just so you know. Generally, I will talk about animal studies from time to time, but usually if I talk about an animal study, I'll let you know it's an animal study, because we can't always correlate an animal study to a human study, although it's a good place to start with research. It doesn't always correlate. Now, one of the deficiencies is zinc, and so I wanted to just pull up this study published in Biofactors on GI diseases associated with zinc homeostasis and demodulation. Why are we talking about GI disease? Because all of these drugs that we're talking about today are GI drugs. For the most part, they're common drugs used to treat GI disorders. And these very drugs that are treating these GI disorders that are known to cause a depletion of zinc are, this is the consequence of a reduction of zinc on the GI tract, right? So GI tract cancers in animal models and rodent models are caused by zinc deficiency. Malabsorption and GI infections, both in animals and in human studies. Inflammatory bowel disease, we've got human, ex vivo, in vitro, animal, and porcine studies that show that. We've got celiac disease in the human model, increasing with zinc deficiency. We've got GERD, gastroesophageal reflux disease in animal models, and then alcoholic liver disease in human in vitro animal mice and rat models. So zinc deficiency has massive consequence on the GI tract and the organs, the accessory organs of the GI tract. So why would you want to deplete that for any length of time? Again, the takeaway here is test. If you're on meds that are known to deplete nutrients, test your nutrient levels. You know, the biggest complaint I hear when I see people in my practice is my doctor won't test my levels. Either my doctor doesn't believe in nutrition or knows nothing about nutrition, or my doctor thinks that nutrition is not important and is dismissive of my concerns. These are complaints I commonly hear. As a matter of fact, if you've heard that complaint, if you've asked your doctor to look at your nutrition and they've dismissed you, let me know in the comment section below. But test those nutrient levels, and it's very important to look at intracellular, not serum. Now, that's not to say you can't look at serum levels or you can't have your serum levels measured. It's just that serum levels are not as accurate when it comes to assessing nutritional status. The serum can fluctuate from day to day very, very wildly based on what you've been eating, based on your stress levels, whereas intracellular analysis or measurement gives you kind of a 6-month overview of your nutritional status. It's much more accurate indicator of overall nutritional status. Kind of think of it as serum levels show you one snapshot or one still shot of a movie, and intracellular levels show you the entire movie, right? So you can draw a lot more inference from that longer status as opposed to that very, very short-term status. A lot of doctors will run serum levels, they'll be normal, and then they'll tell their patients they're not deficient. And again, that's where it can get confusing. So intracellular is what you want to look at. Now, another study here, proton pump inhibitors, a risk for micronutrient deficiency, but are we looking out for this? In this study, these authors were discussing the concern that they had because we've known about this class of medication causing B12 and other micronutrient deficiencies for decades. This is not new information that I'm discussing here. But their concern is that doctors know this. This is part of the knowledge base, but they're not doing it. They're putting their patients on these drugs, but they're failing to test their patients for these deficiencies, or they're failing to accurately give nutrition to these patients as a concern that they may be causing a nutritional problem long term. And so you can see in their conclusion, despite evidence in the literature of an association between long-term PPI use and micronutrient deficiency, the investigation for this by clinicians in a high-risk group was poor and inconsistent, meaning doctors just didn't investigate it, they didn't ask the questions, they didn't look into it. And in this particular study, which was a small study in their cohort, it was 41 patients, so this is not a huge study, but just in this small study alone, they found deficiencies of magnesium and B12 common in patients taking PPIs. So again, magnesium and B12 deficiency have a lot of potential consequences in a negative direction for folks. So it's a simple thing to check for. If you just talk to your doctor, I would say, well, let's just say the argument from the doctor's perspective is they don't believe it. But that's why I put this information out for you. Take this stuff, print it out, take it to your doctor, show him that you know that the prescription he's giving you can cause this, and you're putting him on notice that because you know now he knows that you expect him to take action on it. Again, you have to take control of your health. You can't let your doctor dictate what you're going to do. And whatever you do, don't let it, because one of the excuses they like to give is, well, insurance doesn't cover it. It does if it's medically necessary. And this is where this type of research, if the doctor's not lazy, I mean, I used to get case reviews when I in my practice when I took insurance. I would order nutritional tests a lot, and then insurance companies would come back on me and say, we want We want to claw back that money because we don't believe that you checking nutritional status was medically necessary. And they were never able to claw back any of their money. And the reason why is I would give them stacks of literature like these studies and say, things are medically necessary because this patient's on a PPI. This patient has been on an antibiotic for years. The fact that they are probably nutritionally devoid or deficit is very, very likely. And those very nutritional deficits are also very likely causing or contributing to many of the symptoms that that patient is persistently experiencing. So in other words, the drug-induced nutritional deficiencies chronically caused by the other doctor, there is medical necessity to test for those. And so this type of evidence allows you to hold your doctor's feet to the fire and get them to measure it. This is just another report published in the Journal of Clinical Medicine, the effect of long-term proton pump inhibitor use on blood vitamins and minerals. You can see down here, vitamin D deficit was observed more frequently in the PPI group. Again, vitamin D becoming deficient. Conclusions, our study confirms that chronic PPI users may encounter alterations in some micronutrients involved in bone mineral homeostasis. The effect on zinc levels deserves further investigation. So zinc and vitamin D in this case, and they're talking about bone health, right? So again, you take these patients that have chronic polypharmacy. They're on multiple medications and they're elderly. Because this is what we see. 45 and older are on 5 or more meds in average, and we're talking about US numbers. Okay, so now we've got this spiral down of nutrition deficit. Now in this case, vitamin D and zinc, but you've also seen tonight evidence of calcium deficiency and potassium deficiency and other nutrients, B vitamin deficiencies. Now, in this case, these nutrient deficiencies contributing to bone health issues. Well, bone health, right? So how many 45 or older females on multiple medications are now being told that they have osteopenia or osteoporosis, and now the doctor wants to give them an injection or a bisphosphonate medication to treat this. So you can see my point in giving you this information is a lot of the medical intervention in our world today, a lot of the medical intervention it comes with a good heart. I don't think doctors are ill-intentioned. I don't think that that your local doctor is saying, yes, I'm going to put you on this drug for the next 15 years and I'm going to just rape your nutrition out of your body so that you have more health problems. No, I think most doctors are prescribing medicines without this knowledge, without the knowledge that drugs do deplete nutrients. And because they don't have this knowledge, they also don't have the foresight to do the proper investigation into whether or not those very drugs they're prescribing you are creating nutritional problems long term. And subsequently, they don't have the knowledge to understand, in many cases, that nutritional deficiencies can lead to additional symptoms and subsequently over time can create and contribute to additional disease, as is in this case. Depletion of vitamin D and zinc can lead to bone issues, can lead to bone resorption problems, and can lead to osteoporosis, as well calcium and magnesium deficiency. So if your doctor doesn't have that knowledge and they're not monitoring these things, but here you are, hopefully what you're going to take away from this video is that you have to empower yourself with this information. You have to take this into your doctor if they're not already helping you understand this, and you have to demand better. Look, the only way you're going to get better health care is to demand it, because the status quo, as we have all seen over the past many years, isn't working. If you look at the top causes of death in the US, number 1 is heart disease, number 2 is cancer, number 3 is medical intervention. So we don't have a sterling track record of treating chronic degenerative diseases with medicines as creating stellar outcomes and overall health. America is ranked last amongst industrialized countries in terms of their health relating to chronic degenerative diseases. Now, we're first, we're best when it comes to emergency situations. If you need, a bone to be cast, if you need an emergency surgery to save your life, we've got fantastic medical care. But when it comes to chronic inflammatory conditions and multiple drugs that are being used simultaneously that have nutritionally depleting side effects, These things aren't being monitored, they're not being measured, but they are a major, major force for creating a deteriorating health in our country. And I want you to be aware of it so you can have a more intelligent conversation with your doctor as you move forward.